Hello, and welcome to this mini panel on breast cancer, where I'll be joined by several colleagues who I'll introduce in a moment. My name is Bill Gradisher, professor of medicine at Northwestern University. I'm a breast oncologist there, and I'm joined by several other well-known colleagues, and we'll go around very quickly and have them introduce themselves personally. And we'll start with Sarah Hurvitz.
Sarah Hurvitz, professor of medicine, breast oncologist at University of California, Los Angeles, Johnson Comprehensive Cancer Center. It's nice to be here with you this Saturday.
Norman Womark. I'm professor of surgery at the University of Pittsburgh and chairman of the NSABP and the contact principal investigator of the NRG Oncology Cooperative Group.
My name is Rennie Butler. I'm associate professor in breast imaging in the Department of Radiology at Yale School of Medicine and Yale New Haven Hospital, and it's a pleasure to be here with you all.
Tom Buchholz. I'm a professor emeritus of radiation oncology at the University of Texas MD Anderson Cancer Center and the medical director of Scripps MD Anderson Cancer Center in San Diego.
So I'll get started, and this is a 27-year-old premenopausal woman with stage 4 PT3N1M1 invasive ductal carcinoma of the left breast, which is ER/PR positive, but not strongly positive, and HER2 negative, with bilateral biopsy-proven axillary involvement. So, sort of tongue-in-cheek to start things out, this isn't the typical presentation that we see of a case. And we'll be talking about, in a moment, some of the issues that'll come up are whether this is a patient who's appropriate for curative therapy, because this is not the typical presentation we see every day, and whether this patient is appropriate for neoadjuvant therapy and how one would manage the opposite breast that apparently has no clinical involvement at this point. So let's go on to some of the data here. So this patient presented with a left breast mass for about 2 months, similar to lumps she had developed during lactation in the past, roughly 3 years ago. And her performance status was quite good. And remember, again, this woman is very young, 27 years old. She doesn't have much of a medical history with respect to her gynecologic history. She had menarche at age 14. Her first child, she breastfed for 6 months. No history of oral contraceptives or hormonal replacement. No tobacco, alcohol, or drug use, and there's no family history of breast cancer, for that matter, or any other cancer. So if we get to the specifics, in November of 2020, so just a few, a year plus ago, she was found to have a palpable retroareolar mass of the left breast with evidence of nipple retraction and skin thickening on exam, which prompted a mammogram and ultrasound, and we'll look at those in a minute with Dr. Butler. The left breast had a mass from 10 to 4 o'clock with ipsilateral enlarged nodes. There was nothing that was evident in the right breast. There were a few borderline enlarged lymph nodes. In December, she had a core biopsy of the left breast, which revealed an invasive ductal carcinoma, grade 2, ER/PR positive, HER2 negative, and she underwent an ultrasound-guided needle aspiration of both the left and right axilla based on the findings they were seeing both on clinical exam as well as the imaging. And these were consistent with metastatic carcinoma. An MRI of the left breast showed an enlarged mass up to 10 centimeters in its greatest dimension. It was occupying all quadrants, and there was clearly evidence of ipsilateral axillary adenopathy. And on the right, there were 2 areas in the upper outer quadrant. And again, we'll look at that in a moment. A chest, CT, abdomen, and pelvis showed the left breast mass and retropectoral lymphadenopathy, as well as the axillary adenopathy. But there was no other evidence of metastatic disease. And similarly, the bone scan did not show any evidence of disease. So with that, we can have Dr. Butler comment on the imaging.
The first imaging modality of choice in women under the age of 30 is ultrasound. And in this case of a young woman who presented with nipple retraction, skin thickening, and a palpable mass, the ultrasound findings reflect the clinical presentation. In the image at the upper left, we see that the nipple produces significant acoustic shadowing. It's impeding the ultrasound beam due to the retraction behind the nipple. In the center image, we see that the skin is markedly thickened. This distance between the top of the image and the dermis should measure no more than 2 millimeters. In this case, it's almost a centimeter in thickness. And in the image to the right and the bottom of right of the screen, we see a very large mass, which is mixed echogenicity with both hyperechoic and hypoechoic components, irregular in shape and irregular margins, all of which suggest that it's malignant. When we look at the axilla, on the left side, we see a very large, completely tumor-replaced lymph node. This lymph node has completely lost benign morphologic features such as the fatty hilum. On the right, surprisingly, we also see some suspicion for axillary metastatic disease in the contralateral axilla. It's not as obviously malignant, but the cortex here is also thickened, and the fatty hilum, while it's still present, appears to be displaced and compressed. And here we have a couple of slices from her chest CT, which demonstrates some anterior mediastinal adenopathy.
All right, thanks a lot. And that sort of gives a sense of the starting point in this case. And, you know, there are a number of issues that we'll touch on, and I mentioned those at the outset. But I'd like to ask Norm right from the beginning. You know, we hear about these cases where there's a presumed spread of a primary tumor all the way to the opposite side. And we're often confronted with whether or not this really represents metastatic disease or there is some silent primary that we simply can't find on the opposite side. As a surgeon, how would you think about this kind of case?
As long as there's no extra mammary or regional adenopathy involvement, I would certainly view this as a potentially curative situation. I think that I would treat this individual primarily for her left carcinoma presentation. I would certainly utilize neoadjuvant therapy. I don't think I would obsess over the contralateral breast. This is a 27-year-old, and again, I would be absolutely definitive in treating this individual as a potentially curative presentation. As I said, I don't think I would be sidetracked by the primary or cult primary in the contralateral left breast. The finding of contralateral axillary involvement is troubling. But again, I don't think I would be in any way dissuaded from focusing on a standard of care that would result in a curative outcome.
Let's go to Sarah and just ask, you know, in this patient where clearly there's significant disease, even in the absence of, you know, the red herring of the opposite side being involved, how would you approach this patient with respect to systemic therapy?
Yeah, I agree with what Norm was just saying. She did have some areas of enhancement on the right side. So I'm willing to give her the benefit of the doubt and assume we are dealing with bilateral breast cancer with bilateral axillary adenopathy that's curable. I'd like to see the biomarkers from the right axillary lymph node that was biopsied. So I think she just had an FNA of the right side. I always try and get a core biopsy, and in these types of situations, make sure we understand the biology. And if it is a similarly ER, PR, moderately positive HER2 negative breast cancer, maybe it is more in keeping with stage 4, but, on occasion we'll find a triple negative or a HER2 positive breast cancer on the opposite side, and then we're dealing with 2 curable situations. So I think that can be revealing. She's 27 and absolutely needs BRCA testing, and I would prefer to do germline testing now because occasionally it will impact the way I think about systemic therapy. I'm one of the believers in platinums in BRCA carriers, and especially such locally advanced disease. I think there's enough data mounting to support that it improves path CR rates that I would embrace using it here. And I think a curative intent taxane-based chemotherapy, I think anthracyclines, given the number of nodes involved, would make sense here, is absolutely appropriate. However, if we really are believing this is stage 4 breast cancer, let's say the sternum lit up or she had something else that really did indicate this is not curative, then I think we need to think hard before giving multi-agent chemotherapy, major surgeries, radiation, et cetera. So I think doing the workup now to really establish, is this a curable situation, is important, and knowing more about the biomarkers is also important, including germline testing.
Great. And let me just probe a little bit more, because you made the distinction. If this was a BRCA, there was a mutation present, you definitely use a platinum. But in the absence of that, then we get into the controversy, I suppose, about whether a platinum is really indicated or not.
Yeah, I wouldn't use a platinum here, especially it's ER positive. I don't think we have data to support the benefit of a platinum outside of the triple negative with or without germline BRCA mutation. I would use taxane, and like I said, a ACT regimen would be very standard in this situation.
Now let's assume this patient has a very good response. We won't raise the specter of a PCR, complete resolution of all disease, but a pretty good response. So that lends itself to the question of how we would approach the local therapy. And I would presume in a patient with this size tumor, nodal involvement, we're talking about mastectomy and axillary dissection. Norm, would you do that on both sides? What would you do with the opposite axilla?
I would agree on the ipsilateral left breast. I would do a modified radical mastectomy and axillary node dissection. We in the evolution of clinical presentation, we sort of downplayed the so-called retropectoral node. I didn't see that on imaging. I don't know what the significance is. Again, I don't think I would get sidetracked on it. I think that relative to the contralateral right breast, I would, first of all, I would emphasize the point that Sarah made. I did not realize in reviewing this case that it was only a fine needle aspirate of the contralateral axilla. I think we need tissue. I think we need to confirm that the characteristics of the right side are the same as the left, and that we're not dealing with something unusual or a triple negative breast cancer, which would change the approach to treatment. I would like to go back to the MRI of the contralateral breast and perhaps do MRI guided biopsies if there were any suspicious areas. If we did not find the primary, I don't think I would obsess over it and just go and perform an axillary node dissection on the right side and not vulnerate the breast itself.
Tom, how would you approach local therapy with radiation in this patient? Both the axilla, and I guess then the question, also the opposite breast, would you feel compelled to do anything about that with respect to radiation in the opposite axilla?
Well, I think the important first point is what my colleagues have already made, is to try to gather as much information as possible prior to the start of treatments. And so I agree with Dr. Womark to consider an MR-guided biopsy of those enhancing areas of the right breast and confirm that the biomarkers are no different between the contralateral axilla and the ipsilateral axilla. In addition, I think a better assessment of her regional adenopathy, inclusive of either an ultrasound of the supraclavicular fossas, or Dr. Butler mentioned anterior mediastinum. That's going to be a very important therapeutic decision concerning radiation. It might be that this case could benefit from a PET scan to further elucidate whether she has more extensive regional disease than we can just appreciate on the images shown thus far. I too would want to approach this person with a lack of hematogenous metastases, if you will, more still lymphatic only stage 4 disease. We tend to approach with curative treatments, particularly in light of her young age and excellent performance status. I too agree with the plan for combining surgery and adjuvant radiation. I think clearly the focus would be on giving her ipsilateral left chest wall and regional lymphatic radiation. Again, it'd be helpful to know, do we have to extend the fields to include the upper mediastinal areas? If those were PET positive pre-chemotherapy, I would include those. It's a little bit challenging technically to do that, and it does increase the risk and potential side effects of radiation because we treat a little bit more lung volume, but nonetheless would be warranted, again, if we're taking a definitive approach. With respect to the contralateral, we have to decide, is there a chance that this is an occult primary and indeed she doesn't have stage 4 disease? I think probably it sounds as if this is a contralateral metastasis. And so, like Dr. Wollmark said, I don't think the radiation of the ipsilateral breast is not necessary. She might end up, because of her young age and her genetic status, end up having a mastectomy on the contralateral side anyway. If she did have no disease in that breast on mastectomy, I would focus the radiation on the contralateral side to the axillary region and the undissected axilla and supraclavicular fossa on the contralateral side as well. Inclusive also of, again, if you're going to be treating the ipsilateral internal mammary lymph nodes, you probably could easily treat the contralateral or internal mammary lymph nodes. So these are a special class of stage 4 disease where I do hope that there's potential for curative treatment. I think, again, the most likely biologic spread of this is through the lymphatic channels rather than through hematogenous channels. And so it's a little bit a distinct class of stage 4 disease relative to someone presenting with liver or lung metastases. But even in these settings now, when you do have hematogenous spread, if it's a condition called oligometastases, sometimes we're approaching this in a much more aggressive, potentially definitive fashion as well. And so even if we consider her to have metastatic disease, I think at best she would have oligometastatic disease where it's very appropriate to consider ablative treatments of the metastatic disease site. And that would be consistent with our plan to do a contralateral axillary dissection and regional lymph node irradiation, in addition to definitive treatment on the ipsilateral side.
Great. And Sarah, let me come back to you because I think that, we're approaching this patient aggressively. And if we assume by the surgery and the subsequent radiation that's planned, she's going to be NED, this 27-year-old woman does have ER positive disease. And it raises the question of how to optimize that and also to push you even a little bit more. Is this somebody that you would consider a CD4/6 inhibitor in?
Mm-hmm.
Yeah, so her age is striking, I think tugs at all of our hearts here. And she's got a young baby. I think we all have to remember in situations like this to discuss fertility before starting chemotherapy and make sure that embryo preservation, et cetera, has been addressed if that's within keeping of her goals. But yes, you're right. Endocrine therapy is going to be one of the mainstays of systemic therapy. Dr. Buchholz is correct. There's no evidence of hematogenous spread here, but I think we'd all assume she has microscopic hematogenous spread. She is exceedingly high risk, even if this is bilateral curative intent treatment that we're doing here. She's at exceedingly high risk of a metastatic recurrence. And so I think the systemic endocrine therapy is going to be very important. This is somebody in whom I'd use ovarian suppression. If she's a germline carrier, I would, of course, in this type of situation, recommend oophorectomy when childbearing is complete. I would use endocrine therapy, probably an aromatase inhibitor in somebody like this, but watching the estradiol levels if we're using ovarian suppression. And the use of a CDK4/6 inhibitor here is, in my mind, still a bit controversial. I feel like we're just waiting for the other shoe to drop in this particular patient. This is somebody who I think, if we're considering her to be stage 4 curable, if we believe this is stage 4, then yes, I think it's fully supported to use a CDK4/6 inhibitor. And I would probably actually use ribociclib, because that's based on the Mona Lisa 7 study, in which pre-menopausal women were in the entire population. The use of adjuvant abemaciclib here, if we really thought these were 2 primaries that we're treating with curative intent, yes, maybe I would stretch. It's not yet FDA approved in this indication, but this might be a patient where I would consider it, just hoping we can push out her recurrence. I know I have sort of a, I don't know, cynical look at the way this is going to go. I just, you see these patients in your practices come back with distant metastases 5 years, 10 years later.
Yep, thank you.